On behalf of IAP-Thailand Organization Committee, I would like to welcome everyone to the 14th Asia Pacific International Academy of Pathology Congress, AP-IAP 2025. We are very delighted to have over 700 participants from different parts of the world joining us this year. Just a little housekeeping before we get started. There will be approximately 5 minutes Q&A after each talk, and please feel free to ask your questions or give some comments. If you have any anything to share, any experience by using prepare microphone, and we hope this meeting will be interactive so we can learn from each other. So now, without further ado, let's begin our meeting with the first topic, which is nodal peripheral T-cell lymphoma, current understanding and evolving concept by Dr. Siok Bian from National University of Singapore. Please welcome Dr. Ng.
Good morning, everyone. First, I'd like to thank the organizers for inviting me here to speak to you on this topic on nodal peripheral T-cell lymphomas. I have no conflict of interest to disclose. So you can see from this table, which lists the different entities of nodal PTCL and comparing the 4th and the 5th edition of the WHO as well as the 2022 ICC, and it includes the ALCL, the nodal TFH lymphomas, PTCL NOS, and also a newly described entity, EBV positive nodal T and NK cell lymphoma. So ALCL, we know that ALCL is a CD30 positive PTCL that's characterized by aberrant expression of ALK that is secondary to rearrangement of the ALK gene. And although it is primarily a nodal lymphoma, it can also involve extranodal sites like the skin, the bone, soft tissue, and so on. And most patients will present with advanced stage disease and systemic symptoms. It is common in children and young adults and accounts for 10 to 15% of pediatric and adolescent non-Hodgkin lymphoma. So regarding the pathogenesis, it is mainly driven by fusion of the ALK with a partner gene and leading to the generation of a chimeric fusion oncoprotein and subsequent activation of the JET-STAT pathways. So this table shows you now we know that there are more than 20 partner genes that's translocated with ALK, and the most common that we're familiar with is the NPM1 followed by the TPM3, and the rest of the translocation partners are quite uncommon. We all know that the tumor cells in ALCL is the hallmark cells, and it has this characteristic horseshoe-shaped nuclei with multiple nucleoli, and it can show a variety of growth patterns as well as morphologic appearance. So tumor cells can show the typical sinusoidal growth pattern, or it can be diffuse, or it can be pseudo-cohesive. And tumor cells doesn't always have to be large and anaplastic. They can be small cells, they can be monomorphic, they can look sarcomatoid, so they can be a great mimicker of other tumors. And there's one subtype of ALCL that can look like classic Hodgkin lymphoma as well. And we also are familiar that we need to see strong and diffuse CD30 positive expression to make a diagnosis of ALCL. And characteristic, you'll see a dot-like Golgi pattern of staining. And the expression pattern of ALK indicates what kind of partner gene it is translocated with. And there's often, as we know, loss of pan-T cell markers, including CD3, TCR beta, and gamma. They are often CD4 positive, they express cytotoxic markers, and they can be EMA positive. But not to forget, these days there are other ALK positive tumors such as ALK positive histiocytosis, ALK positive large B-cell lymphoma, ALK positive inflammatory myofibroblastic tumors such as epithelioid IMTs and epithelioid fibrous histiocytosis. And note that they can also be CD30 positive. So be careful, not all CD30 positive, ALK positive tumors are ALCL. What about ALK-negative ALCL? They are also defined by uniform strong expression of CD30, but without ALK expression and without the ALK rearrangement. They can involve lymph node or extranodal sites. And now we recognize several genetic subtypes of ALK-negative ALCL, and the most commonly recognized forms are those with rearrangement with DUSP22 and TP63, but we also know that there are subsets that are characterized by activation of JET-STAT pathways. So regarding ALK-negative ALCL with DUSP22 rearrangement, they have a more distinct morphology characterized by monotonous medium-sized tumor cells as well as donut cells, as illustrated by the top panel H&E section. And this case was submitted by Dr. Sid Hu to the 2023 Society of Hematopathology Lymphoma Workshop. So as you can see, this particular variant of ALK-negative ALCL tend to be non-cytotoxic and do not express p-STAT3, unlike the ALK-positive ALCL, and they can be positive for LEFT1, so sometimes we use LEFT1 as a surrogate marker to suggest the possibility of this subtype of ALK-negative ALCL. And in 50% of the cases, the rearrangement is with a non-genic partner. It's important to recognize this variant because it is associated with a more favorable prognosis. Other than the two systemic forms of ALCL, we also have two localized forms of ALCL, the primary cutaneous ALCL and the breast implant-associated ALCL. The primary cutaneous ALCL, in about 25% of cases, they have DUSP22 rearrangement, whereas for the breast implant-associated ALCL, they are characterized by activation of the JET-STAT pathway as well as frequent loss of chromosome 20q region. A recent study from Dr. Andrew Fieldman, interestingly, have described that we can identify or subtype ALCL into two molecular subgroups, mainly dependent on the absence or presence of activation of the JET-STAT pathway. So the type 1 ALCL, characterized by activation of the JET-STAT pathway, includes the ALK-positive ALCL and the breast implant-associated ALCL, and so they express high p-STAT3 expression on immunohistochemistry. The type 2 ALCL is characterized by the rearranged DUSP22 rearranged and TP63 rearranged cases, as well as some subsets of triple negative ALCL. They do not have JET-STAT activation, so their p-STAT3 expression is low. So the authors in this paper recommended that we can use p-STAT3 as a surrogate marker to divide ALCL into these two molecular subgroups. Nodal TFH lymphoma, we know they are PTCL, characterized by phenotypic and gene expression signature of TFH cells. So while they share this TFH gene signature and mutational profiles, they can show significant morphologic plasticity and overlap in the clinical and phenotypic features. And most of us do a panel of TFH markers in our routine diagnosis of nodal TFH lymphomas, and they include CXCL13, CD10, BCL6, PD1, and ICOS. While TET2 and DNMT3A mutations are common in nodal TFH lymphoma, they are not specific to TFH lymphomas. They can also be present in PTCL NOS, and they can be present not only in tumor cells but also in non-tumor cells such as surrounding T cells, B cells, and hematopoietic stem cells. However, ROA-A and IDH2 are specific to nodal TFH lymphoma, and they are restricted to the neoplastic T cells. ROA-A is specific to TFH lymphoma, and IDH2 is more specific to the AITL subtype of nodal TFH lymphoma that's characterized by vascular hyperplasia and the presence of clear cells. So the initial genetic event is an epigenetic dysregulation where the hematopoietic stem cells and progenitor cells acquire a TET2 or DNMT3A mutation, which is then passed down to the common myeloid and common lymphoid progenitor cells, which subsequently accumulate more mutations affecting normal T cells and myeloid functions, and they go on to develop myeloid and T cell neoplasms. So the diagnosis of the AITL subtype of nodal TFH lymphoma is not difficult. We know it's a nodal T cell lymphoma, it's CD4 positive, it has characteristic FDC expansion and high endothelial venous hyperplasia. And we know that we need to have expression of at least 2 or more TFH markers to make this diagnosis, and it's desirable to have the presence of clonal rearrangement or ROA or IDH2 mutation. And it's common to have EBV positive large B cells in this tumor. So in this panel, we can see that it is expressing CD4 and not CD8. CD21, very useful marker to highlight the expansion of FDC meshworks. And this bottom panel shows the 5 commonly used TFH markers. I'm sure many of you use a combination of 1 or more of these markers, and we know we have to have at least 2 of these markers to be positive. And take note that CD10 and CXCL13 are the most specific TFH markers, whereas ICOS and PD1 are quite non-specific. And if PD1 is one of the 2 markers that you use to be considered positive, you need to see strong and diffuse expression. So the 3 subtypes of TFH lymphomas show very similar clinical presentation, and for the follicular subtype, which is less common than the AITL subtype, they do not show the typical FDC proliferation or vascular hyperplasia or polymorphic infiltrate. Instead, the growth pattern is nodular. They can resemble follicular lymphoma or PTCL-like. And oftentimes, the tumor cells are located in the intrafollicular nodules of neoplastic cells. And because the follicular type and NOS subtype is quite uncommon, there's currently very limited data on the genetics and clinical behavior of these 2 subtypes of nodal TFH lymphoma, but so far they do not seem to differ very much from the AITL subtype of nodal TFH lymphoma. Now, we know that B-cell proliferations are very frequently seen in nodal TFH lymphoma, and that's probably a crosstalk between the neoplastic T cells and the B cells that lead to clonal B cell expansion and proliferative signals to neoplastic T cells. And there can be a broad spectrum of B cell and or plasma cell proliferation in this type of lymphomas. They can be monoclonal or polyclonal. They can be EBV positive or EBV negative. They can look like monomorphic large B-cell lymphoma, polymorphic proliferation, plasmacytic proliferation, or classic Hodgkin lymphoma-like. But the important thing to know that these B-cell proliferations are part of the biology of nodal TFH lymphoma and should not be reported as a composite or a second lymphoma. In this new paper, the authors have performed multi-omics profiling and analysis on AITL type of nodal TFH lymphoma, and they found that the tumor microenvironment plays an important role in the prognosis. For example, cases with B-cell signature are associated with better prognosis, whereas those associated with higher dendritic cell signature predicts for a worse outcome. So therefore, they propose that by immune modulation of the tumor microenvironment, it might be a good way to harness a more favorable microenvironment for treatment purpose. The same authors have identified high-risk genotypes associated with poor prognosis, which is, for example, combination of TET2, DNMT3A, and IDH2 mutations, presence of CD28 mutations or loss or aberrations of PHLPP2, which is part of the PIK3 kinase pathway. And they propose that this provides the rationale for the use of PIK3 kinase inhibitors in future clinical trials to treat high-risk AITL patients. Next, PTCL-NOS. It is a very heterogeneous category of PTCLs that cannot be assigned to a specific category of T-cell lymphoma. But you need to exclude nodal TFH lymphoma and EBV positive type of T and NK cell lymphomas. So they are disease of adults, mainly presenting with advanced stage disease with B symptoms. They can involve nodal or extranodal sites, and they account for about 30 to 35% of all T-cell lymphomas, common in Asia, France, and also common in North America. Generally, they are very aggressive disease with poor response to treatment, and there are some poor prognostic factors, for example, high IPI score, the GATA3 subtype of PTCL-NOS, those with cytotoxic phenotype, and so on. And the morphology of PTCL-NOS is very broad. Tumor cells can look very small with little atypia, monomorphic, or tumor cells can be large and anaplastic looking. The background inflammatory cells also is very variable. Sometimes they are very depleted in inflammatory cells, but there are some cases are very rich in inflammatory cells. We are familiar with this lymphoepithelioid lymphoma morphologic variant of PTCL-NOS, otherwise known as Leonard lymphoma. They are characterized by numerous epithelial histiocytes that can be so prominent to look like a granulomatous inflammation, and so therefore they can mask underlying tumor cells, especially those that are small with little atypia. And some people think that this is associated with a better prognosis than other PTCL-NOS. This is a typical phenotypic profile of PTCL-NOS. They express pen T cell markers, but they can also lose some of these pen T cell markers like CD5 and CD7. They are often CD4 expressing, they are often alpha beta positive, but occasional cases can express TCR gamma delta. About a third of the cases express the cytotoxic phenotype, especially the TBX21 subtype, which I will explain in a while. You can commonly see large B cells that are EBV positive, and a single TFH marker is still acceptable for a diagnosis of PTCL-NOS. CD30 expression, we do see them in PTCL-NOS, but usually the expression is more variable in terms of intensity and not the uniform and diffuse strong positivity in ALCL. PTCL-NOS has a very complex karyotype and often include alterations involving the T cell receptor loci. They have frequent alterations and aberrations involving tumor suppressor genes like P63 and P53, and it's been described that co-deletion of CDKN2A and P10 is quite specific to PTCL-NOS. In 2014, Dr. Iqbal and colleagues described two molecular subtypes of PTCL-NOS based on gene expression profiling. And they described that these two subtypes have unique biology and survival. And 5 years later, in 2019, they described that using a combination of 4 immunohistochemical markers, we can subtype PTCL-NOS into the GATA3 variant or the TBX21 subtype. So the important thing is that the GATA3 subtype is associated with a worse outcome. They are associated with high MYC expression, high proliferation, and higher frequency of genomic complexity. They often show abnormalities involving P53 and CDKN2A and so on. On the other hand, the TBX21 subtype is characterized by activation of the NF-kappa B, less number of genomic aberrations, and more frequent mutations of epigenetic modifier genes. And in the TBX21 subtype, they more commonly express cytotoxic markers, and histologically you will see areas of necrosis and apoptosis. The tumor microenvironment between the two subtypes are also different. The TBX21 is associated with more inflamed and more inflammatory type of microenvironment, whereas the GATA3 subtype is immune depleted. And in this same paper, the authors have also found that the macrophage signature is different between the two subtypes, with a more pronounced macrophage signature in the TBX21 subtype. I want to introduce to you a relatively newly described, I'm not sure whether this is going to be a distinct entity. This paper was published last year in October, where they described PTCL-NOS with loss of SMARCB1 expression or INI1 expression. This tends to occur more frequently in children or young adults. And because right now there's no distinctive phenotype, it is recommended if you have a case of a PTCL occurring in a child or a young adult, you should routinely perform INI1. Okay, this loss of INI1 is due to a deletion of the SMARCB1 locus, and they describe that this tumor is characterized by hypermethylation of T-cell related genes. The tumor microenvironment is more immunosuppressed and exhausted, and there is early preliminary data to show that use of HDAC inhibition might work in some of these patients. So this is our recent case occurring in a 30-year-old female. In fact, this case was reported by Dr. Gareth here in our department. So she came with a diagnosis of PTCL-NOS, and she was treated with multiple lines of treatment, but she developed multiple relapses. Even she was treated with CAR T-cell and did not respond. So you can see on a phenotype there's no remarkable difference from any other PTCL-NOS. It expresses pen T-cell markers. In this example, it was negative for CD4 and CD8. And you look at the INI1, there was loss of expression of INI1 or SMARCB1 in the tumor cell population. And these tumors often can express myeloid markers such as CD117. So remember about this newly described entity. Lastly, I want to talk to you about EBV positive Nodal T and NK cell lymphoma, which is a newly recognized entity in the 5th edition of the WHO classification. It is an EBV positive lymphoma derived from cytotoxic T or NK cells, but it is different from extranodal NKT cell lymphoma in that this is primarily a nodal disease occurring in older patients, more common in East Asia, and many of these patients have underlying immune deficiency. They can have viral infections like HIV, hepatitis B or C. They can have autoimmune conditions or a prior history of angioimmunoblastic T cell lymphoma. There should be no nasal disease by definition. Now, while this is mainly a nodal disease, some patients can show limited extranodal involvement, including rarely the upper aerodigestive tract, the Waldeus ring and tonsil. So this can cause diagnostic confusion with extranodal NKT cell lymphoma. Patients present with advanced stage disease, and this disease has a worse outcome compared to extranodal NKT cell lymphoma and PTCL NOS. In terms of morphology, they can also show a spectrum of appearance, from large monomorphic cells like any other PTCL to pleomorphic to small cell variant, but they typically lack the prominent coagulative necrosis and angiocentric growth of extranodal NKT cell lymphoma. They usually are positive for CD8 and negative for CD56, and this is unlike extranodal NKT cell lymphoma, which is commonly positive for 56 and negative for CD8. Going back. Most of these cases will express TCR beta, but in less than 15% of cases, they can express TCR gamma. Like in this case, the TCR gamma is positive, and majority of tumor cells are positive for EBV. What is unique about the pathogenesis of this lymphoma is that the loss of 14q112 region is very commonly present in this lymphoma, and when compared to the top panel, ENKTL, and the bottom panel, PTCL NOS, you can see that they are less frequent copy number gains and losses compared to these other two lymphomas. And it's characterized by activation of the NF-kappa B and immune-related pathways. What about EBV? Similar to extranodal NKT cell lymphoma, they show a type 2 latency pattern. They are associated with type A strain, and authors have found that structural variations, especially deletions of the EBV genome, is common in this lymphoma. We now know that the most common mutation of this EBV positive nodal T and NK cell lymphoma involves epigenetic modifier genes like TET2 and DNMT3A. And just last year, Dr. Kato from Japan, they have confirmed the association with clonal hematopoiesis in this lymphoma. So this table lists the differential diagnosis of EBV positive T and NK cell LPD occurring in adults and children. So in adults, your main differential diagnosis would be EBV positive nodal T and NK cell lymphoma from extranodal NKT cell lymphoma, and the most important differentiating feature would be the presentation. One is primarily a nodal disease, while the other is primarily an extranodal disease, commonly involving the nasal location, and of course ENKTL more commonly derived from NK cells, so they will express CD56 more commonly than EBV positive nodal T and NK cell lymphoma. However, in children and young adults, the differential diagnosis is different. You need to consider systemic EBV, chronic active EBV disease, systemic EBV positive T cell lymphoma of childhood, and aggressive NK cell leukemia. And the way they present, these three diseases, very similar. They present with systemic symptoms involving the bone marrow, liver, and spleen. And they often present with HLH, hemophagocytic lymphohistiocytosis, at presentation. And sometimes this can be fatal. So the clinicians will have to treat for HLH right from the beginning. And the distinction of T and NK cell lineage is also very important. We know to make a diagnosis of systemic EBV positive T cell lymphoma childhood, it has to be of T cell origin, whereas aggressive NK cell leukemia must be derived from NK cells. So one of my last few slides is to share with you this diagnostic algorithm to nodal peripheral T cell lymphoma. You have to consider ALCL and nodal TFH lymphoma. They are not difficult, just do the necessary IHC. And in patients coming from endemic region, we also need to rule out ATLL. Well, in Singapore, we don't commonly see it, but in Taiwan and Japan, they are not uncommon. And when you are dealing with CD4 and CD8 double negative T cell lymphoma, it's good to do EBA to exclude the EBV positive T and NK cell lymphomas, and it's good to do TCR gamma. If TCR gamma is positive, you have to consider and exclude an extranodal gamma delta T cell lymphoma that is secondarily involving a lymph node, because that is more common than primary nodal gamma delta T cell lymphoma, which is not currently a distinct disease. So finally, in PTCL NOS, if you see it in a young patient or a child, please do INI-1 to exclude this particular newly described cases. And I think it differs between different institutions. In our institution, our clinicians do not ask to subtype into GATA3 and TBX21, so we do not routinely do these 4 markers, but in certain centers, they routinely do it for all their cases of PTCL NOS. And also, this is a slide I want to share with you. If you are dealing with a gamma delta T cell lymphoma, what are the differential diagnoses? So you need to know, first, exclude the extranodal gamma delta T cell lymphoma involving the skin, involving the gut, which is meatal, involve the hepatosplenic T cell lymphoma involving liver and spleen. And then if it's EBV positive, then you have to consider extranodal NK T cell lymphoma. A minority of them can derive from gamma delta T cells. And then you have the nodal EBV positive T and NK cell lymphoma. A subset can be TCR gamma positive. And finally, after you exclude all these things, you may be dealing with this very rare variant of so-called nodal gamma delta T cell lymphoma, which we have described this year in modern pathology. So in summary, I have shared with you ALCL. You have a systemic and localized form of disease. ALK-negative ALCL is genetically heterogeneous. We now recognize, or going to recognize, 2 molecular subtypes of ALCL characterized by the presence or absence of JET-STAT activation. We know that nodal TFH lymphoma is a single disease with 3 subtypes, often associated with B-cell proliferations, and the pathogenesis is due to a complex interplay of epigenetic dysregulation, abnormality of the T-cell receptor signaling and PIK3 signaling pathways, and they have a unique tumor microenvironment. PTCL NOS is heterogeneous. It's well characterized that there are 2 molecular subtypes, GATA3 and TBX21. They have distinct survival and biology and tumor microenvironment. Now this newly described entity of PTCL NOS with loss of INI-1. Remember to exclude this when you're dealing with young patients. And the new entity, EBV positive nodal T and NK cell lymphoma, occurring in old patients, very aggressive, usually T cell origin, loss of 14q112 region, recurrent mutations in epigenetic modifier genes, and association with clonal hematopoiesis, quite similar to the TFH type of lymphomas. So that's my last slide, and thank you for your attention. Welcome any questions.
So next will be the Q&A questions. Okay.
Siok Bian, I'm always learn from you. Thank you very much. I think I got a question here. We used to have an antibody to T cell receptor gamma, and then one day my technician say no more, and then they have a T cell receptor delta instead. But we haven't looking at the discrepancy between these 2 markers. I don't know, in your experience, can you tell us about this different marker?
In our lab, we have a pretty good TCR gamma that still works, thankfully. But actually, TCR gamma may not be entirely specific to gamma delta origin. If you have the delta antibody that works, it is actually a more specific marker for gamma delta T cell lymphoma. If you have both, that's the best.
Hi, good morning. I'm from Chicago. I practice Hempath. So the most difficult aspect of my practice is always T-cell lymphoma, and especially nodal TFH lymphoma. So I have had a case which comes with recurrent lymphadenopathy, but it looks like nodal TFH, but there is no loss of clonality by either gamma or beta TCR gene rearrangement or by flow cytometry. So what is your experience with flow cytometry in nodal TFH lymphomas?
So people have described that the flow cytometry can pick up abnormal TFH proliferation, and they typically show a weak expression of CD3, and if the flow cytometry includes TFH markers, they will be very useful. So in fact, sometimes flow is more sensitive in picking up these abnormal TFH proliferation than histology, but we also have to remember now more and more we are recognizing abnormal TFH proliferation, which can be reactive. They can be seen in marginal zone lymphomas and in reactive conditions. So it doesn't mean all TFH lymphomas must be neoplastic. So we go back to basic morphology. Is it wiping out or destroying the lymph node architecture in the first place? And then if you are dealing with the pattern 1 of the AITL, then we would routinely ensure we see clonality before we call it TFH lymphoma. If it's a pattern 3 and it's obviously wiping out the nodal architecture, in general, for AITL, we would still look for presence of clonal rearrangement, if not presence of the ROA or IDH2 mutation or TET2 and DNN3A, although those are not really very specific for nodal TFH lymphoma. Yeah, thank you.
Right.
Yeah, maybe we have time
I have
for
the issue with the EBV positive T-cell lymphoma of childhood, that you have 3 of them, right, in the previous slide. Okay? The issue is that we have the main differential diagnosis is not on the left and on the right, but on the EBV positive HLS syndrome. And I have a case that, well, come with the classic pattern of this, and they treat it with the HLS protocol, and then the patient, the kid recover. Then they ask me whether it is this one or HLS syndrome, because if it is this one, they will proceed to transplant, but if it's not, they will stop. And I said, I have no way to tell which one is which.
That's a very common issue that we face when we're dealing with young patient with EBV positive T and K cell lymphoma. So when they first present, oftentimes they are quite well with no previous history, and then they suddenly become very sick. They have HLH, which is a clinical diagnosis. And so at first presentation, you may not know what you're dealing with, whether it's going to be a CAEBV disease or a very fulminant disease like the other two, right? So they have to treat for HLH first. And also to remember that to make a diagnosis of CAEBV, the patient must have the symptoms for at least 3 months duration. Yeah. Otherwise, it doesn't fulfill the diagnostic criteria of CAEBV. But in the first 2 months, you wouldn't know, right? So you have to support and treat with HLH first and see whether the patient will behave more aggressively or more in a more indolent way. What I did not include in this slide is the EBV associated HLH condition, which is currently not considered a neoplastic condition. It's currently a hyperinflammatory condition. So that is can present exactly the same way with HLH. You can see EBV positive T or NK cells in the bone marrow, but oftentimes it's self-limiting, and the patient gets well, sometimes even without treatment. So what you need to do is really to monitor and see how the disease behaves subsequently. If you can demonstrate clonal gene rearrangement and abnormal karyotype, then you are more certain you are dealing with a neoplastic process. It can be any one of these 3. Yeah. So in my sign out, when I'm faced with such a situation, I would just give a descriptive diagnosis of EBV positive T and NK cell LPD and give the whole list of differential diagnoses, ask them to do clonality, ask them to do chromosome culture to see whether you can find any evidence of supporting a neoplastic proliferation.